Real life.
Good evening and welcome everyone to the DOS Postgraduate Education Program. And today we are on the 13th lecture of the oculoplasty series. And due to technical issues, yesterday we had to postpone the class. And so we are here today again with Dr. Priyanka V. Walvekar, who will be talking about the topic of orbital cellulitis and non-infective inflammatory diseases of the orbit. Our course coordinator for the day are Dr. Pallavi Singh, who's done her post-graduation and senior residency from AIMS New Delhi, following which she has done an oculoplasty fellowship from UCLA. Currently, she is in private practice, and Dr. Puneet Jain, who's the oculoplasty consultant head at Sharpsight Eye Hospital. Dr. Priyanka Walvekar, the speaker for today, is currently an oculoplasty consultant at Narayana Netralaya at Bangalore. She's done a post-graduation from Netradama Super Speciality Eye Hospital, and following that, she pursued her fellowship in oculoplasty from the prestigious LVPI. She's presented at various national and international forums and has various publications to her credit. Her area of interest include orbit and oculoplasty surgeries, and today she'll be talking about a very important topic, that is orbital cellulitis and inflammatory conditions of the orbit. These topics obviously do come as short notes and are also important and relevant in clinical practice, that you should know the management of such situations, because often you deal with conditions wherein patient presents with orbital cellulitis. You keep getting confused whether it is preseptal, postseptal. You need to give or systemic antibiotics in those situations or not, and various questions which you have in your mind. And I'm sure Dr. Priyanka will be discussing all that in detail. And with that, I would like to hand over the dais to Dr. Priyanka. Ma'am, you can start sharing your screen.
Thank you, Dr. Pranita. Is my screen visible?
Not yet, ma'am. Yes. Screen sharing has started.
Yes, just give me a second. I'll go to big screen. I hope it's visible now.
Still not visible.
Not visible, ma'am. In case there's any issue, I can start sharing the slides and from my end as well.
Sure. But I'm able to see it. That's why I was running it now. Is it okay?
Not yet. Ma'am, you can reshare once again. Stop share and reshare. In case that doesn't work, I will start the screen share for you.
Dr. Priyanka?
Yes.
Can we share? Dr.
I think I will start sharing the screen now.
Okay, I have stopped.
Yes. You can continue the talk, ma'am. I'll keep moving the slides. Dr. Priyanka? Can you hear us, ma'am?
I think the connection sort of gone out again.
Her video is also frozen now.
Yes.
Actually, did I stop sharing screen? It's visible for me. That's why I was going to.
Ma'am, you can see the screen. You can start the talk. It's being shared from my end. You can see on the screen. You can continue your talk, ma'am. Can you hear us, ma'am?
Actually, I can.
Ma'am, can we ask her to log off and log on?
Yes. Ma'am, can you see the screen now? Ma'am, I think your phone will be working well. You can stop the laptop version that you're running.
I think the iPhone login is working well.
Yeah, the
Priyanka, maybe
iPhone
also
login
try
is working well, ma'am. So
Yeah,
you
and
can
then we
stop
can
your
take the
laptop
slides from here.
and continue your talk from the phone as well.
All right. Can you hear me now?
Yeah,
Yes, we can hear you now.
Okay. Is it like without any lag? I think there'll be an
Yes,
issue
yes.
if I
Yes,
switch
you
on
can
the video.
continue.
Can I just continue like this?
Yes, yes, that's fine. Perfectly fine, ma'am. You can continue the lecture. I'll move the slides.
All right. So, a very good evening to everyone. At the outset, I'm really grateful to Delhi Ophthalmic Society for this opportunity to be a part of this postgraduate education program. So, let us begin today's discussion on two vital topics: orbital cellulitis and non-infective orbital inflammation. So, before starting, I would just like you to go through this clinical scenario. So we had a 6-year-old girl who presented to our clinic with her mother, and she complained of swelling of the lids, redness, pain, watering in her left eye, and this was a 4-day history. It was sudden in onset and it was rapidly progressing, and it was associated with outward bulging of the affected eye, and that they had noticed in 2 days. And in a day, the vision also got blurred. And on retrospective history, we could elicit that she was running a fever for about a day. And there was history of severe cold and respiratory congestion for about a week, and there was no treatment that was sought for that, as per the parents. And previously, also, the child had few recurrent episodes of cold and respiratory infections. Apart from that, in any case of the sudden onset redness and swelling, it is obviously important to elicit the history of any antecedent trauma or any surgical intervention, which was not present in this case. So as you can see, this is the clinical image. And with that, with the tap, we can see that here there is eyelid edema. And obviously, there is erythema of the periocular skin. You can also see that there is matting of the cilia and the eyelashes. And here you can see that the eyelids are also very tense. So obviously, you cannot do an intraocular evaluation without manually retracting the upper eyelid. So the vision at presentation in that particular eye, which we could elicit after manually retracting the eyelid, was about counting fingers at 1 meter. And also there was a dystopic ocular position, apart from the other findings that we already discussed. So facial symmetry was obviously not maintained. So clinically, again, to run you through it quickly, there was eyelid edema, and on manual retraction, there was conjunctival congestion with chemosis, and there was discharge and matting of the cilia, and we could elicit a rapid afferent pupillary defect with the pupillary reaction, and also a fundus examination revealed that there was disc edema and also venous dilatation. So obviously, in this scenario, you would also expect restriction of the extraocular motility, and that was found to be about -3 in all gazes. And when we did a Hertel's exophthalmometry, we found that there was about 5 millimeter proptosis when we compared it to the other normal looking eye. And in the systemic examination, the child seemed to be conscious and oriented. She had a temperature of about 102 degrees Fahrenheit, and there was tachycardia with about 110. So in this scenario, what would be your provisional diagnosis? And the most important question, why would we say so? So moving on, obviously, this seems like the inflammation of the orbit because there is proptosis. So we would provisionally diagnose it as left-sided orbital cellulitis. Now, looking at the picture which is below, we can see that there's the orbital structure, and in close proximity, you have the sinuses. So there is ethmoid sinuses, which are present medially. There is the frontal sinus, which is superiorly, and the larger sinuses, which is the maxillary sinus, which is present inferiorly. So why we also came to the conclusion of orbital cellulitis is one major thing from the history that there was a preceding cold and a respiratory infection. And the mother did give us recurrent episodes of these rhinitis that the child was having. And there was no trauma or any surgical intervention that we could attribute this sort of sudden inflammation to. And along with that, this child had no other systemic comorbidities. So this was our provisional diagnosis. Now, when we talk of orbital inflammation, it is very important to first understand what are the signs of inflammation. So if we revisit our Robbins, we all know that the 5 most important cardinal signs of any inflammation are calor, which is for heat, rubor, which is for redness, tumor, which is for swelling, dolor, which is pain, and functionalisa, which is nothing but loss of function. So these are the 5 cardinal signs of any inflammation, not just with respect to the orbit, but in general, these are the 5 signs. Now, let us try to look at why each of these happen. So before that, let us just run through the symptoms that she had. So pain, redness, swelling can be attributed to the inflammatory process that was happening. And when there is a complaint of blurring of vision or diminution of vision, obviously there is an optic nerve involvement, right? And when we talk about signs, the lid signs, which is the lid edema and the conjunctival congestion, along with the chemosis, again, could all be attributed to inflammation. And like I mentioned, the sign of proptosis, when that is picked up, obviously it means that the orbit is involved. So there is an orbital pathology that is going on. And when there is restricted ocular motility, the muscles are infected. And when we elicit systemic signs like fever and tachycardia, you know that the focus of infection is somewhere in the body, and possibly it is an infectious or an infective pathology. So like I said, signs would be pain and diminution of vision. And the symptoms and the signs, we would say lid edema, proptosis, motility restriction, and optic nerve involvement based on the severity of the condition. So let us try to understand why each of these things is happening in a case of orbital cellulitis before going into actually defining what orbital cellulitis is. So firstly, why is there pain in case of orbital cellulitis? So we have the mechanical stimuli, we have the thermal stimuli, and obviously chemical stimuli via the inflammatory mediators. So the mediators are basically the substance P, the prostaglandins, leukotrienes, all of these which cause the nociceptor activation or the pain pathway activation, and that leads to dull, aching, and persistent pain, right? And these mediators which are released usually by the injured cells which are present and the inflammatory cells. And that is how the increased nociceptor excitability happens, and that is what causes the hyperalgesia or the pain. And these are basically transmitted by the polymodal nociceptors, which is via the type C fibers. So we have it via in case of the eye and the orbit specifically, we have it via the ophthalmic division of the trigeminal nerve and the oculomotor, as well as the fourth cranial nerve, trochlear nerve. So that is about the pain. So there is nociceptor activation. Now let us try to understand how and why the lid edema occurs, right? So in case of lid edema or any swelling that we are seeing in case of any inflammatory pathology, basically there's a component of venous stasis. Now what happens is when there is any inciting factor like an inflammation or an infection, there is obviously vasodilatation of the blood vessels. And that is when there is an imbalance that occurs between the hydrostatic pressure and the oncotic pressure. So this kind of imbalance is what causes fluid outpouring, and that is when the extravasation occurs and there is lid edema. Now, why does proptosis occur? So we already said that when there is proptosis, we mean that there is orbital involvement. So when there is any inflammation, there is obviously increased volume of the orbital content. When we speak of inflammation in the orbit, there is increased volume of the orbital content, and that is happening in a very closed space. So that is why out of the excessive pressure, there is proptosis which is occurring. Now, in orbital cellulitis, the inflammation causes the increased volume, right? And there can be 2 types of proptosis that can occur in case of orbital cellulitis. We have the axial, which is along the axis of the globe. And that occurs, then it would point to a more intracorneal inflammation or a more diffuse involvement where all the compartments of the eye are affected. And you can have abaxial, where in specific cases like subperiosteal abscess, or when it is outside of the intracorneal space, that is in the extracorneal space with an extracorneal abscess. So orbital cellulitis need not be presented with just axial proptosis. We can also have abaxial proptosis based on the location of the involvement. Now, we spoke about all of this. Now, why does extraocular motility get restricted or limited in cases of orbital cellulitis? Now, the simple, straightforward answer to that is involvement of the muscles, right? That is, there is spread of the inflammation into the extraocular muscles. Now, this becomes the most cardinal, one of the cardinal signs of orbital cellulitis when you're trying to differentiate it from other causes of ocular inflammation, when there is extraocular motility restriction. Now, when we clinically examine this, it is always important to examine keeping both the eyes open, especially in unilateral cases, because that would allow us simultaneous comparison, and we could also grade it accordingly and see how much worse it is from the normal looking eye. Now, when we speak about loss of vision, it need not be exactly just loss of vision. It can present with initial diminution of vision or blurring of vision, and eventually it can also be associated with loss of vision. So why does that happen? So when there is mechanical pressure because of increase in orbital volume, that can cause pressure over the optic nerve fibers, leading to, diminution or blurring of vision. Now, when there is an abscess pressing onto the optic nerve fibers, and if that abscess is drained, the pressure is released, obviously that would become more reversible. So the blurring of vision would improve. But in certain progressive conditions, what can happen is there can be ischemia of the central retinal artery and the ophthalmic artery. There are reports which speak of that, and in that case, that blindness would be irreversible. So this is a case of a CRAO, that is central retinal artery occlusion, which is occurring in a case of orbital cellulitis. And here, the main cause was the intracorneal mechanical compression of the central retinal artery, and that occurred secondary to inflammation as well as the edema of the orbital tissue. So it can happen is what is important. It is not that every case of orbital cellulitis you're going to see, complete blindness with a central retinal artery occlusion. But in progressive cases with pressure on the central retinal artery or the ophthalmic artery, this can be a devastating complication. So with this background, let us try to look at what exactly is orbital cellulitis. So any inflammation that involves the postseptal region is known as orbital cellulitis. Now we know that the layers of the eyelid, there is skin, and then there is subcutaneous tissue, and then there is the septum, the orbital septum, after which we have the tarsus and the conjunctiva. So now when there's anything which is present anteriorly to the septum, we call it as preseptal, and obviously anything posterior to that would be the postseptal region. So that inflammation of that area would be termed as orbital cellulitis. Now, the most common etiology is extension of infection from the paranasal sinuses or from the adnexal regions. And as I demonstrated in the image before, it is most commonly the ethmoid sinus, which is in close proximity, present medially to the orbit. Right now, other causes can be infections from the adnexal region. So we have the lacrimal drainage system. So any dacryocystitis can present with an orbital extension, or we have a spread from the adjacent ocular structures. That is, in a setting of panophthalmitis, it can be associated with orbital inflammation as well. Any dental procedure where an infective focus gets initiated via that route, and that spreads into the orbit and causes orbital cellulitis, or a long-standing retained orbital foreign body which can elicit an inflammatory reaction. Infected tumor, most commonly in infected tumor scenario, we would see something called as pseudo-orbital cellulitis because it is not purely an infective source, but nonetheless that can be possible. Of course, in mucormycosis or the black fungus infection, and from any distant hematogenous spread of an infective focus, which can reach the orbit and cause orbital cellulitis. So overall, these are broadly some of the causes of orbital cellulitis. So based on the severity, how severe or the region of involvement, there is a Chandler grading system which grades the orbital cellulitis as grade 1 for preseptal, grade 2 for orbital cellulitis, grade 3 when there's a subperiosteal abscess formation, grade 4 when there is an orbital abscess, which could be either intraconal or extraconal, and grade 5 when this abscess progresses into cavernous sinus thrombosis. So if it is important to note here that preseptal cellulitis should not be regarded as benign, because that is where if that is left untreated, then it can progress into orbital cellulitis. So that is why here in this classification, it is preseptal cellulitis becomes stage 1, right? Okay, so now when we said in the etiology that ethmoidal sinusitis is a common cause of orbital cellulitis, especially in younger children, why is that, right? Now, those are the sinuses which are the most developed and the most pneumatized in this age group. So in children especially, ethmoid sinuses followed by maxillary sinuses attain their maximum pneumatization first. So because of which, most of the infections are from these two regions, especially ethmoidal sinuses, and frontal and sphenoidals are yet to be fully pneumatized. So to understand the pathophysiology, it is just important to note that in the preteen children, why we say preteen is because by that teen age, most of the sinuses are well developed and pneumatized. So in the preteen children, they are more prone to sinusitis and therefore orbital cellulitis as well. And 91% of the cases, it is known of pediatric orbital cellulitis are usually from the ethmoidal and maxillary sinusitis, as I explained. So the focus of infection, to briefly summarize, in children is most commonly the ethmoid sinus followed by maxillary, because these are the ones that are pneumatized first. And in adults, it is frontal sinus followed by ethmoidal sinus. Now, we know that ethmoidal sinuses are the ones that are the most common area of infection that spreads into the orbit, right? Now, how does that infection actually spread? So there are certain points. First is the medial orbital wall is composed of a thin bone known as the lamina papyracea. Firstly, it is very thin. And apart from that, it has multiple foramina, which allows for passage of the blood vessels and the nerves. Now, these vessels, especially the veins, they are valveless. So between the orbit as well as the adjacent structures. So that basically allows bidirectional passage of the pathogens. Now, apart from that, there can be certain congenital bony defects where the person can be predisposed to developing infections, recurrent infections, and some acquired bony defects, say in a case of trauma, in any orbital fractures, and so on. So these are the important factors which attribute to easier spread of the infection from the ethmoid sinus into the orbit. Now, why is sinusitis more common as the age advances? So it would be interesting to know that as one ages, right, the sinuses grow in size. So their ostia becomes relatively smaller. And that causes reduced drainage. And that because of that reduced drainage, what happens is there is stasis of all the secretions within that space. And that is how secondary infection can happen. And that is how sinusitis is very, very common. So in case of orbital cellulitis, what happens is, like we already discussed, ethmoid and maxillary sinuses, they complete pneumatization first. So the foci of infection can easily spread via the floor from the maxillary sinuses or via the medial wall, like I said, through the lamina papyracea from the ethmoid sinuses. Now, from the clinical anatomical point, let us look at certain surgical spaces which hold importance in case of orbital cellulitis. Firstly is the intraconal space. So this space is enclosed within the muscle cone. As we can see, it is present behind the globe. And this contains the optic nerve, the intraconal orbital fat, the blood vessels, and the nerves. Right. So now when we say abscess, it means that there is inflammation as well as necrosis of the intraconal or the, depending on the location, extraconal fat. Now, intraconal orbital abscess, like we previously said, will attribute to axial proptosis. Now, apart from intraconal space is the extraconal space. So that is obviously the space which is outside the extraocular muscles within the bony orbital walls. Now, that contains the adnexal structures like the lacrimal gland, the superior and inferior oblique muscles, the trochlea, the extraconal orbital fat, and of course, the superior and inferior ophthalmic veins. So inflammation involving any of this can spread into the orbit, more specifically into the extraconal space, and form abscesses. Now, apart from this, we have the subtenon space. So in the subtenon space, it is basically this region which involves between the globe and the tenon's capsule. So any during anesthesia, local anesthesia infiltration, or any during that, it can enter into the subtenon space, and that can be a potential of spread of infection or inflammation from the subtenon space into the intraconal space. So it is also important to understand that this can be a possibility for or a potential route of spread of infection. The next space that we would be of concern would be the subperiosteal space. Now, that is the potential space that exists between the periorbita and the bony orbital wall. So what happens in this space especially, there is loose attachment to the orbital bones except at the margins and at the suture lines. So that is why classically when you have a subperiosteal abscess, it sort of contours along the bone, and classically it is dome-shaped. And this is why when it can cause an abaxial proptosis, because A, it is in the extraconal space, and B, when it is superior subperiosteal abscess, it kind of pushes the globe down, and that is how it can attribute to abaxial proptosis. Now, we spoke about how preseptal cellulitis is grade 1, and that can progress into orbital cellulitis. So let us see how we can differentiate between the two. So to just put it very simply, these are the 5 points that we can use to differentiate preseptal from orbital. The picture to the left bottom is preseptal cellulitis. So in that, you can see that there is lid edema, there is conjunctival congestion, but you can clinically evaluate and see that there is no significant proptosis, and also there was no blurring of vision in this particular case. And if you have to examine the ocular motility, you would know that there would be no ophthalmoplegia. So the 3 important factors that differentiate preseptal from orbital is A, proptosis, that is involvement of the orbit, 2 is diminution of vision, and 3 is ophthalmoplegia, because the amount of eyelid edema and conjunctival congestion can be almost mimicking one another. So just to quickly have a recap, we already said that Chandler has, based on Chandler's grading system, based on the severity, it is from preseptal to orbital, subperiosteal abscess, orbital abscess, and finally grade 5 where there is cavernous sinus thrombosis. Now, apart from this, there is also a Jane-Rubin classification, which is specifically for bacterial orbital cellulitis. So here there are just 3 grades. Grade 1 would be preseptal cellulitis. Grade 2 would be orbital cellulitis with or without intracranial complications, that is spread of the infection into the intracranial region. And 3, orbital abscess with or without intracranial complication. Now 3 can be subdivided into A and B, where we have 3A would be orbital intraorbital abscess, and 3B would be a subperiosteal abscess. So basically, preseptal cellulitis, orbital cellulitis, and orbital abscess. This is how the grading for specifically bacterial orbital cellulitis by Jane and Rubin. So this would help us to kind of prognosticate. When we talk about grading and severity, it would help us to prognosticate the condition and also realize what investigation should be done at what stage, and accordingly, what treatment should be included or should be initiated at what stage. So let us go through the investigations which play a very important or a key role in diagnosing orbital cellulitis, or more specifically, the staging. So certain laboratory investigations would include the total and differential leukocyte count. And in that, we would invariably notice an elevated ESR or an elevated CRP, which would, contribute to an inflammatory state. Blood culture, but most of the time, less than 2% of the yield is positive. Then the sample which we send from the abscess drainage, almost in 25% of the cases, no growth can be seen. But of course, 75% of the chance you would be able to identify the infective organism. And if the sinuses is involved, then a sinus swab or an aspirate from the sinus would help us to correlate with the orbital pathogen. Now, apart from this, also, if it has progressed, like we said, intracranial involvement, then a CSF tap would also be contributory to diagnosing the pathogen. But this is all, of course, in cases where the orbital cellulitis has progressed. Now, when we also talk about laboratory investigations, another important thing is to culture from the specific sources of infection. Because when we do that, like, for example, the infection, the foci of infection is in the sinus. So when we send that, so the culture would yield the diagnosing pathogen, and there would be appropriate antibiotic selection, because once you know the pathogen, we can initiate the exact antibiotic treatment. And that would help us to prevent the progression to the abscess formation. So like I said, when there is just inflammation, it would be a cellulitis stage. And when there's necrosis of the adnexial structures like the fat, it would lead to abscess formation. And that would be more critical, as it would be rapidly progressive if no initiation of treatment has been done. So sometimes there can be a negative blood culture that would indicate an absence of bacteremia, of course, but higher yield in children is noted, usually compared to adults, and it is almost about 33%. So most of the time in cases of children, we have to suspect an infective pathology. So sometimes when we're from an abscess also, after a drainage has happened, if there is no growth, it would obviously mean that there is spillover of some of the inflammation from the orbit, and it may not be a true representative of the orbital infection. Now, after these laboratory investigations, we have to obviously get into orbital imaging. So the investigation of choice would be a CT or a computed tomography. And that would be usually essential when we are suspecting that the cellulitis stage has progressed into abscess, because we would be able to localize where the abscess is present, and that would help us to either plan a drainage or try to initiate antibiotic therapy, a suitable antibiotic therapy. So all cases of orbital cellulitis is usually, it's not mandatory for very initial stages of, say, preseptal cellulitis or a very initial orbital cellulitis to be imaged. But most of the cases, it is done to rule out an orbital abscess, like I said. And the best advice that we would give is a non-contrast orbital along with paranasal sinuses, because that is where we would suspect the route of infection to be, or the foci of infection to be rather. And so you would advise an axial and coronal 2mm cuts. That is just the investigation that we would send in for ruling out the presence of an abscess, or to just generally see the progress or the condition. So now this is a CT scan. So as you can see, it is a reconstructed sagittal cut, and this is how a subperiosteal abscess would look on a CT scan. So you can see that it is classically dome shaped, and it usually is present in the area from which the inflammation or the infection has spread. That is, so here it would indicate that the foci of infection is the frontal sinus. So most of the times they present that classical dome shaped appearance. And this was when CT scan would help us to locate the abscess and also would guide us on the aspiration and the drainage of the abscess. So this is just to show the difference between initial preseptal cellulitis and the intraconal spread of the orbital cellulitis. So in the first image, you can see that the inflammation is more on the preseptal. It's more limited over there. So we could call it as the stage 1 of orbital cellulitis. Whereas in the image below, you can see that there is a patchy densities which are noted right behind the globe, and that is obviously involving the intraconal space, and that would be obviously a stage 2 or a stage 3 orbital cellulitis. So when we speak about preseptal and compare it to orbital cellulitis, in cases of preseptal, it is most of the time homogeneous. You don't see any patchy densities, whereas in cases of subperiosteal abscess, the density is much more patchy, and that patchiness is because of the gas fluid level, that is the causative organism, which can be anaerobic. So that is how you can appreciate the gas fluid level. So homogeneous versus a more patchy appearance of a abscess. Yes, so this would also, in cases of an abscess, you can see a well-defined density, and there is rim enhancement. So that would point out to a more localized region of the abscess. And again, that would help us to drain it so that the orbital pressure is reduced and the inflammatory signs also reduce. So now certain key points about imaging in orbital cellulitis is, firstly, when we talk about the CT scan, right? Why is it important? Just for briefly summarizing it, to localize the abscess, to rule out the sinus involvement, the etiology, to establish that whether it is a vascular malformation, whether, to rule out the differential diagnosis. And also, like I said, sometimes a retained metallic foreign body can also simulate orbital cellulitis. So you want to rule all of that out, and that is when CT scan would be of importance. Now, MRI, of course, there is a question about using MRI in cases of orbital cellulitis. Now, that is mostly done when there is more posterior involvement, when we're suspecting that, and also when we're suspecting perineuritis or any cavernous sinus thrombosis or intracranial complication has occurred. So that is when it would be more advisable to advise an MRI in these cases. And of course, when you're suspecting a long-standing infection which is not responding to routine antibiotics, so that is when you would also look at fungal infections. To rule out that, MRI would be a better option. So clinical or symptomatic improvement may precede reduction in the size of abscess on CT scan. So that is also important to note. Now, MRI in orbital cellulitis, of course, like I just discussed, it is also to rule out any optic nerve involvement, to in fact evaluate the optic nerve. And in this case, you can also see that there is enhancement mostly in the posterior orbit. Yes, and in the picture that appeared to the left, you can see that the cavernous sinus region is taking up enhancement. So this is a case of a cavernous sinus thrombosis, where the route of spread of infection was more posteriorly, and that is how the infection has involved and reached the stage of cavernous sinus thrombosis. Now, apart from CT and MRI, is there a role of ultrasonography as an investigative modality in orbital cellulitis? So let us just look at what are the features of ultrasonography. So sometimes there might not be immediate access to CT or an MRI. So in such cases, we can use ultrasonography also as an investigative modality in orbital cellulitis. So just let us look at what all are the features that we can see. So firstly, the advantage in ultrasonography would be that it is easily available, and it usually produces repeatable results. So it helps us to distinguish subperiosteal abscess from an orbital abscess. And it is mostly actually the use in cases of myositis, where muscle involvement is there, and also it can pick up an orbital foreign body. But of course, the resolution when it comes to posterior orbit would be very, very poor, and it would require a much more learning curve to sort of pick up that if in cases of absence of any CT or MRI availability. So this is how this is an ultrasonography in a case of orbital cellulitis. So you can see that this is the orbit, and in the subperiosteal abscess would usually have medium to low echogenicity, and it would involve the area just adjacent to the orbital wall. And the thing is that once you have a diagnosis, once you're suspecting orbital cellulitis with a sonography, it does not negate the need for CT. CT scan is always the preferred investigative modality of choice because that would help us to exactly locate where the infection is. You can examine the sinuses simultaneously. It would help us to point out the location of an abscess and so on. But this would come in handy in case there is no access. So now we've talked about bacterial cellulitis being the most common form of orbital cellulitis, especially in children. Now that versus fungal. So what are the pointers of a fungal orbital cellulitis? Firstly, clinically, it might not be very, very different in terms of presentation. But however, there are certain fungal orbital cellulitis which can present as a very slowly, with lesser signs and symptoms in comparison to bacterial. So they have a much more indolent course, and invariably a history of immunosuppression can be elicited, and there could be a history of any functional endoscopic sinus surgeries. So especially when we image these kind of cases where we're suspecting a fungal etiology, there would be more involvement of the posterior orbit. And usually the inflammation is slightly lesser compared to a bacterial inflammatory episode. So the key distinguishing factors between a bacterial and fungal orbital cellulitis would be, like I just ran you through it, one would be the posterior orbit would be involved mostly, and the infection, it would be more of an insidious course. There is very minimal inflammation in comparison to a bacterial type, and there is early ophthalmoplegia. So you would have a case with mild inflammation and limitation of muscles, and immediately, you wouldn't suspect it clinically to go into vision loss or blurring of vision, but that can happen. So that would indicate a more posterior involvement, posterior orbital involvement, in a much more indolent course. So usually, from the lungs and the orbit, it can happen, and it can spread into the sinus and the airways. And that usually affects the posterior ethmoid and the sphenoid sinuses. So that is what is important distinguishing factor when you talk about orbital versus fungal. And in mucormycosis, it was caused because of vessel thrombosis and tissue necrosis. So when we look at this clinical image, you can see that the inflammatory signs are much lesser. It does not have that much amount of chemosis, and there is no very darkly congested conjunctiva. However, there is significant lid edema, and there is also abaxial proptosis and a dystopic ocular position. So this is when you would suspect an orbital apex involvement, that is more posterior involvement. And if you see the systemic history of this patient, there was uncontrolled diabetes. So that would point towards an immunocompromised state. And this patient also presented with complete blindness. So this is where we would suspect a central retinal artery occlusion. So this is the image. So you can see that there is posterior orbital tissue enhancement. So you can see there's hyper intensity involving the posterior orbit, and that is also the intensity is can be picked up in the cavernous sinus region. So this is a stage of posterior orbital involvement progressing into cavernous sinus. So this was a case where you can see that the ethmoid sinuses are cleared out. So it was post a functional endoscopic sinus surgery. And there is also apical involvement, like I discussed, and the superior orbital fissure widening. So now we know this much about, with this background about orbital cellulitis, it is also important to know what are the mimickers so that you can rule out and the treatment can be initiated. So this is a case of a 1 week history of inflammation and proptosis. So this was, yeah, and as you can see that there is collection of um, uh, 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 the globe. Yeah, so the orbital cysticercosis. So as you can see that there is a cystic lesion which is present right behind, and there is a scolex or a region, a specific area of hyperdensity that you can pick up. And this was a case of orbital cysticercosis. So that would also present with a inflammation. Now, this is a child who presented with lid edema, pain, congestion, which was present since 4 days. And there was variable proptosis since birth. And this was increasing with the upper respiratory tract infection. And as you can see, there is some patchy density in the, in the post intraconal space. And there is transcompartmental involvement. That is, it's involving the preseptal and the extraconal as well as the intraconal involvement. And there is cystic density as well as hypodensity that you can see. So this would be an orbital lymphangioma that can mimic an orbital cellulitis. Now, in this case also, you can see that there is conjunctival congestion, there is some amount of chemosis, and there is subconjunctival hemorrhage. And if you see, there is a slight change in the hue below the lower lid margin as well. So there is inflammatory signs that we can pick up. The vision was reduced, and there was RAPD that we could pick up on a clinical examination. And here in the CT scan, you can see a hyperdense area of hyperdensity, focal hyperdensity, which is present in the posterior orbit. So that is an orbital cellulitis, which is occurring following a trauma. So in the clinical image, you could see ecchymosis. So that itself is an indication that there was probably a traumatic event. And that is why a CT scan needs to be ordered to look for any foreign body. Now, this is a child who presented with the leukocoria or altered pupillary reflex, which was present since 3 months, and there was sudden proptosis. So as you can see, in these kind of cases, obviously, a tumor should be suspected. And like I was mentioning previously, any tumor can mimic a cellulitis. So it is termed as pseudo-orbital cellulitis. And this is an MRI image demonstrating the intraocular tumor with the areas of increased hyperintensities. So that was an orbital retinoblastoma. Now, another differential is when you look at this image, there is an orbital cellulitis sort of a picture that you can see externally. There is inflammation, there is lid edema, there is erythema, there is tense lid, there is excoriation over the periocular skin. And this patient also was retroviral positive. So obviously in these conditions is when you would suspect a tumor. And here you can see the stretching of the optic nerve. And then there is also, yes, so these are the cases where you would suspect an orbital lymphoma because there's also transcompartmental involvement. There is stretching of the optic nerve. So although they may simulate orbital cellulitis, it is important to image because you would know exactly where to classify them as. And these are certain differential diagnosis that needs to be kept in mind in cases of orbital cellulitis. So when we talk about bacteriology of the orbital cellulitis, Staph aureus is the most important or the most commonly presenting organism. And of course, the incidence of methicillin resistance Staphylococcus aureus should be borne in mind. Apart from that, even epidermiditis is another important pathogen. And of course, anaerobic infections, which are very less common in the pediatric age group. So in the pediatric age group, also you would suspect Haemophilus influenza and strep pneumonia. But of course, now because of vaccination, there is a reduced incidence of the same. So, but these are certain causative organisms that need to be borne in mind. So the pathogens in the orbital cellulitis from the sinus flora, usually in children more than 9 years or in the adults, they would almost always have mixed infection, or mostly it would be anaerobic species. So antibiotic resistance, if noted, then it would be good to drain it and send the aspirate for culture. And in children below 9 years, it is mostly single species, like I mentioned, Staph aureus or epidermidis, and they're mostly aerobic. And this is just to compare. So indications of medical therapy would be when it is grade 1 orbital cellulitis, that is preseptal. So there is empirical therapy in orbital cellulitis and periosteal abscesses in the young children. So these were where we would, go for more conservative or medical line of treatment. And if the lid edema and inflammation is present and there is no proptosis, there's no ocular motility restriction and vision is preserved, then that would be mostly preseptal we are dealing with, and that would resolve with medical line of treatment. But if there is proptosis, EOM limitation, vision is compromised, then it becomes orbital cellulitis. And that is how this algorithm would help us to stage the two. And in preseptal, most of the times we would look for the mild signs, and such as like milder signs would be present in more than 1-year-old children and in adults, and less than 1-year-old children with immunocompromised state can present with more, drastic or dramatic symptoms. So oral antibiotics would help when it is mild, and intravenous antibiotics would be the role in case of older children or in cases of immunocompromised conditions. Yeah, this is important to remember, that if there is no improvement even after 2 days of treatment, then you would go for imaging. Now, what treatment for choices of empirical antibiotic in cases of orbital cellulitis? It would be amoxiclav. Then there is second and third generation cephalosporins. And in cases of MRSA, when there is resistance, vancomycin would be the way forward. And in anaerobic coverage, it would be metronidazole. And antibiotic resistance usually is noted to these 3 things. It would be intravenous fluoroquinolones, that is ciproflox. It could be to penicillin, and it could also be to amoxiclavulinate. So in these conditions is when, once you suspect resistance or there's no response, you have to change the antibiotics. So in fungal orbital cellulitis, usually IV amphotericin B versus liposomal amphotericin B would be the way forward for rhino-orbital mucormycosis. And other than that, posaconazole and voriconazole for invasive aspergillosis, when diagnosed, would be useful for the treatment. So amphotericin B, because that is the major drug that is used for fungal infections, nephrotoxicity would be the most important adverse effect that needs to be borne in mind. And they can present with azotemia, renal tubercular acidosis, or tubular acidosis, or with hypokalemia. So it is important to monitor their renal function test, and the cumulative dose should not exceed 5 grams. So the last aspect of orbital cellulitis is, what are the indications of corticosteroids in cases of orbital cellulitis? So this would be intravenous corticosteroids when there is inflammation that is tempering, there is reducing, it helps to reduce the orbital pressure and prevents optic nerve compression. It has of antifibroblast activity, and there's quicker return to the baseline vision, and there is reduced hospital stay in cases of patients who are admitted. So when would you initiate is when we already discussed this. There's no response to antibiotic or the routine therapy after 48 hours, or when you've given a coverage of an antibiotic for 48 hours. That is when you would treat it with that. Now, systemic corticosteroids, would you give them in fungal orbital cellulitis is the question, because obviously in fungal infection, steroids would be contraindicated, but it would be usually done to treat the sinusitis when there's to cause nasal decongestion, saline irrigation. Intranasal corticosteroids can be given, and that would facilitate drainage. And of course, a function endoscopic sinus surgery would also help. So indications of surgical therapy, especially in older adults when we have an abscess, on the scan and there is no response to medical therapy, or there is worsening of the symptoms and you notice an intracranial spread, and in cases where there is a long-standing retained foreign bodies, and then these are the cases where you would definitely go in for a faster or a quicker surgical intervention as against a medical management. So this is just a brief algorithm of all the points that we discussed, which explains about how after 48 hours, if there's no improvement, you would go in for imaging and also start intravenous medications. So some of the complications of orbital cellulitis can be corneal opacification when there is exposure keratopathy or neurotrophic keratitis. Apart from that, you can also have intraocular effects like endophthalmitis, septic uveitis, IOP rise, and then there can be posterior orbital changes where there is optical neuritis, compressive optic neuropathy, or there can be globe tenting that we saw with the stretching of the optic nerve, and there can be residual ocular motility deficits. So these can be some of the complications that can occur with it, and intracranial complications also, where it can fast progress to aggressive infections, can progress to cavernous sinus thrombosis, especially with the posterior orbital involvement. There can be an intracranial abscess and also meningitis, which is reported to about 2% of the cases can progress to this. So incidence of all of these complications is almost equal in preseptal and orbital. So quickly about cavernous sinus thrombosis. So from the mid-face orbit and the paranasal sinuses, there is drainage posteriorly into the cavernous sinus, and that can progress to involve the cranial nerves, which are present in the posterior orbit, and they can also involve the contralateral sinus and the surrounding meninges, leading to inflammation of all of these structures. So these are the same, MRI of a case of cavernous sinus thrombosis. So it is important to initiate intravenous antibiotics for this for a longer duration of time, and anticoagulants for thrombolytic therapy. So the bilateral inflammatory signs and ophthalmoplegia should hint to the cavernous sinus involvement. Now, intracranial abscesses usually present with headache, fever, and altered mental status. That is a very key clinical evaluatory point. When the patient is disoriented, then that is when you would suspect an intracranial spread, and immediate abscess drainage would be the way forward. And along with that, IV antibiotics, which are covering all the organisms that we are suspecting, would be a good way to treat these conditions. And neurological symptoms are usually subtle, very subtle, especially in children. So it needs to be picked up based on the clinical presentation of children specifically, and of course in adults as well. So this is a frontal lobe abscess that you can see, where there is an increased intensity that you can make out in the frontal lobe. So that is the frontal lobe abscess. So imaging in these cases with high index of suspicion is key importance. And of course, in all of this, to conclude about the orbital cellulitis, it is always important. Counseling plays a major role because you have to explain the etiology, and also about immediate reassurance, and also you have to address concerns which are related to visual recovery. So these are all extremely important. So now that would bring us to the end of orbital cellulitis. So now to quickly run through the next topic of discussion, which is non-infective inflammatory orbital diseases. So let us broadly classify them as specific and non-specific. And under specific, we have the infections that we already discussed. There are certain distinct entities like the vasculitis, or those with specific histopathology like granulomatous disease. Now, under non-specific, usually we would have myositic or myositis, which is involved. It could be lacrimal, it could be anteriorly, it could be diffuse and apical based on the region which is affected. So this is non-specific orbital inflammation, or the IOIDs that we're talking about. So we will look at both of this individually. First, the non-specific orbital inflammation. So first, in that, let's look at myositic. So this was a 41-year-old woman who presented to us with swelling, redness, moderate pain, and redness, which was persistent for a long period of time. And she had already received oral steroid therapy and had also received local triamcinolone injections. And she was already started on an immunomodulator. Oral azathioprine was given, and the biopsy was attempted elsewhere, but it was inconclusive. And she kept having multiple episodes, and it kept worsening over a period of time. So in the MRI, you can pick up that the medial rectus is enlarged. There is belly enlargement, and there is also increase in contrast uptake in this. So a diagnosis of myositis was made and the oral steroids were stopped. A biopsy was done, which proved to be myositis inflammation involving the medial rectus. And she was given IV methylprednisolone or IV steroids, about 3 gram. And this is how she improved over a period of time. So when we talk about orbital myositis, it is the most common NSOID, and these usually are isolated, like the case that we just saw. It could be recurrent or it could be atypical. So isolated and recurrent, most of the times they present with periorbital inflammation, swelling, and retroorbital pain and painful ocular movements, especially. But atypical are the ones which may not present with these symptoms, and they contribute to about 7% of most of these cases. But these can present with very unusual CT presentations, and they can be progressive, and sometimes they can even involve the optic nerve with excessive enlargement of the muscle. And here, biopsy only would be the way forward. So orbital myositis is the most common type of non-specific orbital inflammatory syndrome, and most commonly the muscle involved is the horizontal recti, which is the lateral rectus. We saw a case of medial rectus involvement, and the sensitive investigation would be an MRI scan, like we saw, a contrast enhanced one, especially because you're looking at the horizontal recti. We would talk about the axial and also the quasi-coronal cuts. And the first line of treatment obviously would be oral corticosteroids. If in cases of non-responsive to that or prolonged corticosteroids obviously cannot be given. So in those cases, the patients can be given immunosuppressive agents, and also in isolated cases for the symptoms, NSAIDs also should be initiated. So this is just an algorithm again, where we speak about unilateral involvement, where there's only one muscle involvement, whether it is isolated. So the treatment would be a non-steroidal drug based on symptoms or moderate doses of steroids. And if it is waning off, then you observe. But if it is waxing and waning, it obviously means that it is likely recurrent. And here it would be bilateral involvement, and multiple muscles or apical component might be there. So higher doses of pulsed steroids should be given. And in atypical cases, like we discussed, biopsy would be the way forward. You have a histopathological diagnosis, and then treatment can be accordingly initiated. Now let us look at this case. So here there is a protrusion of both the eyes, and this was a history of a year. There was also redness, which was present since a week. The patient is a known smoker, and on the CT scans in the axial cut, you can see that there is typical belly enlargement and there is sparing of the tendon. And in the coronal cuts, you can see that the muscles are very significantly enlarged and almost nearly compressing the optic nerve. So this is a case of thyroid eye disease with this thyroid optic neuropathy. So this is a very, very common differential diagnosis when it comes to myositis. And even in this case, as you can see, after the patient received IV methylprednisolone and 2 weeks into the treatment, the patient was looking much more better. So this was an acute congestive stage with a dysthyroid optic neuropathy. So because this is the most important or the most common differential diagnosis we would see in our clinical scenario, it is important to distinguish the two, right? So TD on one hand would have a more insidious onset, and you would have other associated lid signs like the lid lag or lid staring, the Von Grefé sign. All of that should be assessed. There is also a more pronounced proptosis in this, and usually inferior rectus is most commonly involved. There can be limitation, but here the key differentiating factor would be the tendon sparing involvement of the muscle. And in cases of orbital involvement, there would be more of the tendon involvement. However, having said that, a tendon sparing does not rule out myositis, and a tendon involvement does not rule out thyroid eye disease. This is broadly how clinically they would appear, but of course, there can be overlapping features. So next let's move on to lacrimal variant of NSOIDs. So this is a case of a 37-year-old gentleman who had a protrusion of the right eye since 20 days. And when a detailed clinical evaluation was done, as you can see, there is congestion in the interpalpebral fissure area, and you can see that the lacrimal gland is very, very dilated. And also there's congestion at the point of insertion of the lateral rectus. So this patient was planned for an incision biopsy, and a collagen vascular profile was also advised, and it turned out to be an lacrimal gland inflammation. Now, this is the most common, second most common type of NSOID after orbital myositis. And here, usually, there is again classic signs of inflammation like pain and tenderness, and there is congestion of the temporal portion of the upper eyelid and conjunctival fornix. You can palpate the lacrimal gland is enlarged and palpable. It's tender. There's also a S-shaped deformity of the eyelid. And on clean evaluation, you can make out that there is pouting of the lacrimal ducts as well. So again, on the CT scan, these features can be picked up, where you can see that very nicely that the lacrimal gland is enlarged. So 50% of the patients with apparent inflammation are usually lacrimal gland. They have associated systemic involvement. So routine biopsy is usually recommended, and most of the times they're associated with lymphomas and Sjogren's syndrome or Wegener's granulomatosis. So that is how that needs to be ruled out, and it is always a good idea to do a biopsy. Of course, from the orbital lobe of the lacrimal gland, and not to disturb the palpebral lobe. Now, the third variant, like we discussed, diffuse and anterior type. So this is a 13-year-old boy who presented with recent onset protrusion of the right eye and drooping of the right upper eyelid. As you can make out that the structures cannot be very well defined on the CT examination, and he had a long-standing presentation for about 2 years. So in this case, orbital debulking was done, and he was started on 12 pulses of IVMP over a 6-month period. And when a repeat CT scan was done, there was no signs of inflammation. So if you look at diffuse NSOIDs, the anterior as well as diffuse, by anterior I'm saying in front of the globe, they almost have similar features, and both of them present with extraocular motility, muscle involvement as well as the nerve involvement. And on imaging, you can see that there is scleral and choroidal thickening, which could be appreciated on the coronal section, and the whole of the orbit is obscured because of the infiltration, especially in cases of diffuse NSOIDs. So this need not mean that it is, say, a tumor. You have to correlate clinically as well as radiologically to reach the diagnosis. So like I said, the differentials in this case, one would suspect an orbital cellulitis and any sudden event in a pre-existing lesion. So you could suspect that there is hemorrhage within a vascular lesion, or it could be a local ocular inflammation, that is scleritis, uveitis, which is with an associated systemic involvement, which is causing that. Or they could be, in cases of children, we would suspect or think of leukemic infiltration, metastatic neuroblastoma, and rhabdomyosarcoma, all of which can be ruled out by ancillary tests. So these are just the differential diagnosis that should be borne in mind. Now, moving on, let us look at this 30-year-old lady who presented with slightly decreased vision in the right eye. And she presented with diplopia, which was present since 3 days, and muscle pain. So apart from that, clinically, you could only see upper eyelid swelling and some amount of mechanical ptosis. And the CT scan showed an ill-defined isodense lesion in the posterior orbit, which is extending right into the apex. So this would be NSOIDs with the involvement of the optic nerve, so perineuritis, and after 2 months, long-standing dosage of oral tapering steroid, she improved to the clinical image below. So usually all of these NSOIDs would warrant a longer course of oral steroids, and if they remain unresponsive even after this long period, then it would be a good idea to shift them onto pulse therapy. So quickly, the fourth part would be the apical, where the inflammation, non-specific inflammation usually involves the orbital apex. So in this scenario, we would rule out disproportionately functional abnormality when it is comparing to the clinical image. So the degree of inflammatory signs and the functional abnormality are very disproportionate. So this invariably is always a diagnosis of exclusion. So only after all the specific causes, all the gamut of the things that we discussed are ruled out is when we would come to a conclusion to this, that it is non-specific. So the differential, so what are the specific apical orbital inflammations? It could be Tolosa-Hunt syndrome, it could be metastasis or tumor and lymphomas or fungal infections, all of which would have a specific history, and that is how you would rule out and then diagnose it to be non-specific. Yeah, this is a case of meningioma on HPE, and it mimics an orbital apex syndrome, but this was actually a meningioma and radiotherapy was advised. And similarly, you would have a lymphoma, which is mimicking an orbital apical inflammation, and even fungal infections. Now we've finished with the non-specific. Now coming to specific, just briefly an overview, because specific would involve a lot of conditions which would point to the pathology. So let us look at this 43-year-old lady who presented with the right eye protrusion, and this was a long history of 5 years, and MRI was ordered, which shows an ill-defined isotense lesion, and that is mostly involving the right intracorneal as well as the extracorneal space. And if we look closely in the coronal cuts, we could appreciate that the maxillary sinus was also full. But and in those cuts itself, we could appreciate that the optic nerve was separate from the mass. So a diagnosis of Wegener's granulomatosis was made. So usually for Wegener's granulomatosis, the diagnosis is on the constellation of clinical, radiological, and pathological features. And the key cardinal features would be bilaterality and any preceding respiratory tract infection, including mastoids. So that is most often missed. So that should be borne in mind. And hearing loss or any sort of ear infections and episodic involvement should all point to a Wegener's granulomatosis. So this was just to give a brief idea. So when we speak about specific, it can broadly be divided into infections, vasculitis, under which we discussed Wegener's granulomatosis. There is a long list of inflammatory pathologies that happen, and also there are granulomatous diseases. But today, like foreign body granulomas, sarcoids, tuberculosis, xanthogranulomatous diseases, Sjogren's disease, Castleman's disease, and also Rosai-Dorfman, which is actually a sinus lymphadenopathy, which can have the extranodal involvement where orbits can be affected. So that is extremely rare. So we will just touch upon what is fairly common. So an investigation was done to assess any extraocular muscle enlargement. And when this was assessed, it was known that inflammatory orbital diseases were the most common reasons for this, whether specific or non-specific. And second most common, contributing to about 6.7%, was the Wegener's. And sarcoidosis was a close third. And apart from that, even histiocytosis, that is Erdem-Chester's disease, and xanthogranuloma, which contributed to about 5% of the entire specific orbital infections. So briefly about these. So when we speak about NSOIDs, we already saw that because muscles are involved, diplopia becomes the most common feature. Usually single muscle is involved, and the belly or the site of infection can be affected, and there is pain, proptosis, swelling, that is inflammatory signs that you can see. And sometimes these can be associated with IgG4 related disease, and that is when there is bilateral involvement, and infraorbital nerve enlargement can be seen in these cases. So this is a brief overview of IOIDs. Now, coming to Vigenous granulomatosis, we just discussed that there can be single muscle involvement, usually the levator, the muscle belly, and as well as the muscle at the point of insertion can be involved. And there is invariably paralytic diplopia. Sarcoidosis, which is the third most common type, here there's multiple bilateral muscle involvement. The belly as well as the point of insertion is involved. So here the symptoms are basically because of the muscle disease per se, and also because of the enlarged muscles which cause a mass effect. So that is important. Now for histiocytosis, it is usually the Erdem-Chester's disease and xanthogranulomas. So here, an important point to remember is if it is associated with xanthogranuloma, it would invariably present with ptosis and enophthalmos, whereas in the Erdem-Chester's spectrum of the condition, there would be a proptosis. So these are most common differential diagnoses of extraocular muscle enlargement with specific causes. So these are the four most important ones, and that is why this has been listed out here. So briefly, the histopathology would correlate to the area that is affected. So in IOIDs, most commonly the orbital fat is involved. So you would see the flat globules on the histopathology as well. And in the sclerosing type, invariably it is the lacrimal gland and the ductules that we can make out, the tubular acini in the picture to the top right. And in sarcoidosis, you would have the typical granuloma presentation. And in granulomatosis with polyangiitis, that is Vigenous granulomatosis, you would have the typical image. So based on the area of involvement, we would see typical histopathological features. So there can be infiltration of the histiocytosis in cases of Rosai-Dorfman, where most of the histiocytosis have engulfed leukocytes, and that can be a typical picture of emporipolesis. But those are all very, very rare scenarios where just the orbit is involved, and that is when you would have the respective histopathological image. And IgG4 related disease, orbital disease, is another important entity where usually it involves the lacrimal gland as well. And this can also be present in the spectrum of non-specific orbital inflammatory disease. So here they typically present with lymphoid hyperplasia, having that typical germinal centers that you can see. There could be fibrosis noted. There can be infiltration with the plasma cells and the eosinophils, and also plasma cells which are immunoreactive for IgG4. And that is how the conclusion to IgG4 specific condition would be the way forward. So the important key features in general for non-specific orbital infections, or specific orbital infections which are non-infective, is to remember that they can have no specific cause, especially in cases of non-specific, but the location, like I said, and degree of involvement, it correlates very well with the orbital imaging. And the key to diagnosis would be rapid steroid response. So that is pathognomonic. When we say it is idiopathic and a trial of steroids is given and rapidly the clinical symptoms improve, then that would be pathognomonic. And failure of resolution with medical therapy always warrants biopsy, except in lacrimal gland inflammation where the threshold is lower, because obviously we cannot keep biopsying that area. So biopsy is usually done in persistent, recurrent, or inconclusive disease. So thank you for your time. Hope this was a good learning experience.
Thank you so much, Priyanka. That was fantastic. I think that's probably one of the most comprehensive talks we've had on cellulitis. I'm quickly going to give you one question from the audience.
Okay.
So one of the residents has asked that we know that CT will Devashish Bishoy has asked that why is CT our investigation of choice when we know that MRI is going to tell us more about like soft tissue features, they are more apparent with MRI. So why do you say that CT is your investigation of choice?
Okay, so thank you, Debashish, for that question. But like I was already mentioning, most of the times orbital cellulitis is, associated with abscess formation. And most of these abscess, especially when we're talking about subperiosteal abscess, that would be located in an area where there is bony structure. That is, like I mentioned, it has the classical dome-shaped involvement and it is more loosely adherent at the suture lines. So when we say CT, we are able to see that as well. And when we talk about the paranasal sinuses also, like I mentioned, the root of infection can be from the ethmoids. So you can actually see the concurrent infection spreading there. That is one. And secondly, nobody is going to, unless it is very advanced stage, it is not going to involve the optic nerve in all stages. So for most of the posterior orbital involvement is when you would advise an MRI in comparison to a CT, because the delineation of an abscess is much better on a CT scan.
Right. And as you said, if you need any sort of surgical management, it's always easier to have CT scan because we have
because the breach, from the frontal sinus, especially in adults. So if there is a breach, intracranial spread, all of that, it's most important.
Right. Thank you so much for that. We have another question, though I don't think it's sort of Mary Tigga has asked, what is the best management in a case of bilateral failed external DCR? And if it's okay with you, Priyanka, I'll answer it.
Yeah, sure, go ahead.
Yeah, so bilateral. So if it's a bilateral failed external DCR, Mary, what you have to first figure out, why has it failed? Was it a problem with the surgery? Is there any unusual anatomy or anything? So yes, of course, revisit your first surgery with the surgeon, and maybe do some sort of nasal endoscopy to see if there's any other problems there. And then the management initially would be, of course, doing a re-DCR with using either a stent or a mitomycin C, any sort of antifibrotic agent. But that's kind of the way you go about it. First, you figure out what the cause is, and the second thing is you take measures to sort of make sure that it doesn't happen again. So thank you so much, Priyanka. That was a fantastic and probably one of the most comprehensive lectures we've ever heard about, inflammation in the orbit. I wish we had this when we were residents, because it's a bit of a confusing topic, and it's just helpful to have everything broken down so well, because it's super helpful for the residents. And thank you so much for your time. Thank you for your time on 2 consecutive days. Double engagement for you, but thank you so much. And Dr. Pranita, would you like to add anything?
Yes, thank you. Actually, thank you, Dr. Priyanka. Despite of all the troubles and the technical glitch, you managed to take that class so very well, and such a comprehensive lecture, beautiful images and beautiful radiological images and clinical images which well depicted the topic. Thank you so much for your time and effort to prepare this class. We really appreciate your time and efforts. So I think with that, we come to an end of this class. And our next class will be on Thursday, which will be on another important topic, that is orbital tumors, and that will be taken up by Dr. Rashmi Gupta. So thank you, Dr. Priyanka and Dr. Pallavi, for your time. With that, we come to an end of this class. Good night. Good night.